again. I'm Dr. David Flieger, President of our Texas Medical Association. Thank you for joining us tonight for TMA's TeleTown Hall on COVID-19. This is the second COVID-19 Town Hall hosted by your TMA. I'm joined by Dr. Diana Fite, TMA President-elect. Diana.
Thank you, Dr. Flieger. We are finishing the process of calling more than 60,000 physicians across Texas. This obviously takes several minutes. Over the next hour, you will hear an update about the COVID-19 pandemic in Texas. You'll hear information about how to keep your practice operating during this difficult time. You also will hear about how to utilize telemedicine to broaden your capability to care for your patients. Tonight's speakers joining Dr. Flieger and myself are Dr. Joseph Valente, who is a member of TMA's Board of Trustees, Dr. Wendy Chung, Chair of the TMA Task Force on COVID-19 and Chair of TMA's Council on Science and Public Health, Dr. Trish Pearl, an infectious disease specialist and member of the TMA Task Force on COVID-19, and Dr. Ezekiel or Zeke Silva III, a member of TMA Council on Socioeconomics and co-chair of the AMA Digital Medicine Payment Advisory Group. We will answer your questions periodically throughout this call, so stay tuned for instructions on how you can ask them. And we want your answers to poll questions. We'll tell you how to reply to those when the time comes. Now, TMA has devoted nearly all of our resources for the past 6 weeks to COVID-19. We want to help you help your patients and your community as we confront this worldwide pandemic. We understand you face two major threats right now: the very real threat this virus poses to your patients, your practice, your staff, your families, and yourself, and the equally real economic threat this pandemic and stay-home requirements have posed to so many medical practices across Texas. Earlier this year, your TMA Board of Trustees convened a task force on COVID-19. This task force has created FAQs, documents, podcasts, and other guidance to help you and your patients and to help you manage your practice. Dr. Flieger, we all know these are extremely important issues, and we appreciate our doctors joining us for this crucial information tonight.
Yes, Diana, we knew it was important to convene another town hall meeting to provide more essential information for our fellow doctors. We hope everyone can benefit by joining us tonight. Since TMA is offering continuing medical education for this event, we will ask a question at the end of this call for CME credit. I must also tell you that the policies and standards of the TMA, ACCME, AMA require that speakers and planners for continuing medical education activities disclose any relevant financial relationships that they may have with any entity producing, marketing, or reselling or distributing healthcare goods or services consumed by or used on patients whose products, devices, or services may be discussed in the content of the CME activity. The content of this presentation does not relate to any product of a commercial interest. Therefore, there are no relevant financial relationships to disclose. The TMA designates this activity for a maximum of 1 AMA PRA Category 1 credit. The TMA is accredited by the ACCME for continuing medical education to provide education for physicians. Physicians who remain on the call for at least 53 minutes will automatically receive CME credit. That's 53 minutes, so hang on. And for those of us who just joined us, don't worry, we'll repeat the beginning information for you at the end of the hour. Okay, so here's how to ask us a question or make a comment at any time during this event. Press the 0 key on your phone keypad. A TMA staff member will greet you. Please succinctly, I say succinctly, tell him or her your question. Soon we'll call on you to ask your question of our experts. We're going to try to begin with clinical and public health questions and move on later in the hour to practice and telemedicine questions. Now it's our first opportunity to hear from you, the thousands of physicians across Texas on tonight's TMA call. Dr. Fite, what is your first poll question of the night?
Thank you, Dr. Flieger. Here is the first question for everyone in our audience. About which of the following would you need more resources and information? Press 1 on your phone keypad if you would need more information on how to access testing and the different testing options. Press 2 for information on how to prepare you, your practice, and your patients for easing of shelter-in-place restrictions. Press 3 for more COVID-19 resources to use and share with your patients. Press 4 for information on how to communicate better with public health authorities and entities in your community. Press 5 for more than one of the above. Again, that's press 1 if you would need more information on how to access testing and about testing options. Press 2 for information on how to prepare you, your practice, and your patients for easing of shelter-in-place restrictions. Press 3 if you want more COVID-19 resources to use and share with your patients. Press 4 for information on how to communicate better with public health authorities and entities in your community. And press 5 for more than one of the above. We will tabulate the results and report them back to you shortly. David?
Thank you. Now I'd like to introduce our first speaker, Dr. Wendy Chung. As we mentioned earlier, Dr. Chung not only leads the TMA's COVID-19 task force, she also chairs TMA's Council on Science and Public Health. Dr. Chung will update us on COVID-19 epidemiology, testing, personal protective equipment, and recent efforts by the task force. Dr. Chung, thank you for joining us.
Thank you, Dr. Feit and Dr. Flieger, for convening the second TMA TeleTown Hall on COVID-19. I also wanted to express my appreciation to the other physician presenters on this call, and special thanks to Dr. Trish Pearl, Chief of Infectious Diseases at UT Southwestern Medical Center, for joining me tonight to field members' public health questions. So I wanted to start off by sharing some numbers to give a general overview of the current status of the novel coronavirus pandemic in Texas. As we know, the Texas Department of State Health Services announced the very first case of COVID-19 in our state on March the 4th. And today, just 7 weeks later, according to the Texas Case Counts dashboard, we have reported a total of over 19,000 cases of COVID-19 and 495 deaths. We have been encouraged to see a decrease in the rate of newly diagnosed cases over the last week or so, due in part to the shelter-in-place orders that were established throughout the state. But per the governor's recent executive order, as we look towards the prospect of opening commerce, our communities, and our medical practices, we are calling for our state leadership to do so in a careful, science-based, methodical, and data-driven manner. The COVID-19 task force has been working diligently with TMA staff to produce helpful resources to address your public health questions on infection prevention and control, testing, treatment, what to do when you have PPE shortages, and more. These resources are available on TMA's COVID-19 Resource Center webpage. The availability of personal protective equipment, or PPE, has also been a top priority for TMA, and our association leaders, such as Dr. Flieger, along with task force members, have been actively advocating for the PPE that physicians out on the front line direly need. We have also been working with other TMA groups with specialty expertise, such as the Subcommittee on Behavioral Health and the Subcommittee on Transplantation and Transfusion, to develop resources on physician and patient mental and behavioral health, as well as to address questions related to convalescent plasma and serological testing. Regarding testing, there are a number of tests for COVID-19 being marketed to physicians right now, some of which have not been granted an FDA Emergency Use Authorization, or EUA, nor have they been reviewed and validated for accuracy. We have heard of physicians purchasing these tests, which are appealing in their terms of their low price and accessibility, but these tests end up being unreliable. So we recommend to those listening to please remember to check the FDA EUA website to make sure that the company and the test that you're interested in purchasing have at least been granted FDA EUAs. Also, since TMA has been getting many questions about serological tests or antibody tests, I wanted to take this opportunity to explain a little further. Many serological tests are being inappropriately marketed to doctors as a way to detect SARS-CoV and to diagnose COVID-19. However, serology testing should not be used to make a diagnosis of active COVID-19 infection because antibody production is not present at detectable levels until several days after symptom onset. This is why serologic testing is not approved by the FDA as a diagnostic test for COVID-19. Instead, we foresee serologic testing playing a role in helping to identify which persons, such as healthcare workers, may have had past infection and hence some level of immunity to the disease. And serologic testing currently also has a role in confirming which individuals can donate convalescent plasma. We want to emphasize that whenever possible, clinicians should rely on molecular or PCR tests to diagnose the presence of SARS-CoV-2 infection, and that FDA approves only molecular testing or PCR testing to diagnose active COVID-19. So we are wanting to keep our initial comments short and just to make sure that we leave time for as many of your questions as possible. But please know that the TMA Task Force is committed to continuing to serve as a resource for you. Thank you for the opportunity, and now back to Dr. Flieger.
Thank you, Dr. Chung. We appreciate your joining us to provide this valuable information. And of course, we thank you for your service and leadership on the task force and the council. You've done a great job, and I know we've been working that task force literally night and day. So we thank you for all you're doing for us. For those of you who joined us in the middle of our presentation, Dr. Chung will repeat her presentation at the end of the hour, since many of the people are just getting on the call, given the 60-some thousand docs that we've had to call tonight. In just a moment, all of you doctors listening in will have your first opportunity to ask a question. A reminder to do so, please press the 0 key on your phone keypad and briefly tell the TMA staff member your question. Then continue listening to the call and the cues, and at the proper time, we'll call on you to ask a question of the panel. Remember, we want to begin with clinical and public health questions. But first, Dr. Fite, you have the first poll question results.
Yes, I do. Here are the results of our first poll question. We asked about which of the following would you need more resources and information. I'm going to go in descending order. So 41% of you say you need more information on how to access testing and the different testing options. Now, 28% would like more than one of the above. So then we go down to 23% need information on how to prepare you, your practice, and your patients for easing of shelter-in-place restrictions. Only 5% would like more COVID-19 resources to use and share with your patients, and only 3% want information on how to communicate better with public health authorities and entities in your community. Back to you, Dr. Flieger.
Great. Thank you, Diana. Now it's time for you to ask your questions of our panelists. We have a few people waiting in the queue. For those of you not in the queue yet, remember to ask a question, please press the 0 key on your phone keypad and brief the TMA staff member on your question or comment. Soon we'll call on you to ask your question. Our first caller is Dr. Dobaria, probably not pronouncing that very well, from Dallas, Texas. You had a question for us.
Yes, thank you for doing this. This is wonderful and helpful information. We have the many patients who are already been diagnosed or who isn't able to get tested and put on like isolation or the self-quarantine, and they are feeling fine. So what is the time when we can let them go back to work or release for work?
Dr. Pearl, would you like to take that for us?
Actually, I think it would be better for Dr. Chung.
Okay, go for it, Wendy.
Hi, this is Dr. Chung. Thank you for that question. So in terms of return to work for public service workers, for essential workforce who are non-healthcare professionals, the recommendation is a minimum of 7 days from the onset of symptoms and at least 3 days from resolution of fever or improvement in symptoms, whichever is longer. So that is generally what we like to see in terms of the minimum length of time before somebody goes back to work.
Excellent. Our next question is from Dr. Scott Leidy from Austin. Scott?
If you could comment on immunity after recovery from COVID-19. There's a lot of stuff in the scientific press and lay press about whether or not immunity is real in this disease.
Wendy, what do you think?
Dr. Pearl, why don't you go ahead?
It's a wonderful question, and it's the million-dollar question right now. So what we can tell you is there's actually very little known about coronavirus immunity in general. If you look at the endemic coronaviruses, they may have a temporary immunity, but there also is some data to suggest that that builds up over time. For example, younger people are more likely to get endemic coronaviruses than older people. When you start talking about the novel coronaviruses, the data are less clear on whether or not there's residual immunity. There are some examples with MERS-CoV and SARS that suggest that there is a longer immunity. Whether or not it's lifelong is unknown at this point. In terms of SARS-CoV-2 or the virus that's causing COVID-19, again, the data are unknown. There was a paper that was published last week that suggested that rhesus monkeys do not get reinfected with it at this point. So I think all of us suspect that there will be short-term immunity, maybe a year to 3 years, but I think long-term, whether we end up with residual immunity at this point is really unknown, and we hope we can answer it soon for you.
Excellent. Thank you. Our next question is Dr. Nancy Graves from Texarkana, and I'm going to have Zeke Silva. This is one probably in your area. So, Dr. Graves, what is your question?
Okay, my question's on telemed, which they were going to do at the end, but I guess I'll ask it now. I'm wondering if we're going to get reciprocity with any other state. I see patients in Arkansas but haven't obtained an Arkansas license yet and cannot see them via telemed. I also see patients in Oklahoma. We don't have reciprocity with them either.
Yeah, Dr. Graves, this is Zeke Sullivan. It's an excellent question. So if you think of kind of pre-COVID, the requirements for licensure generally required that a physician have his or her licensure in the state where the patient was receiving the treatment. In this instance, it's imagine a telemedicine interface. For the duration of the emergency declaration, that's waived, which essentially allows the reciprocity you're describing in the following sense. As long as you're enrolled in the Medicare program and you have a license in the state where you are enrolled, then you can provide services to patients who are physically in other states. Now, there is a process. You have to actually reach out to what's called the provider enrollment hotline for the Medicare administrative contractor in the state where you're providing services. So, Dr. Graves, in your example, that would be that individual within the state of Arkansas. But assuming that all takes place, yeah, it's completely appropriate and makes complete sense and is encouraged to do so.
All right, very good. Let's see. Our next question would be Dr. Tagadosi. I probably once again butchered that, and I apologize, from Houston, Texas.
Yes, this is Dr. Tagadosi. Thanks for this teleconference. I'm a pediatrician. My question is, how long after a patient who is COVID-19 positive can be given vaccination, granted that the patient does not have any symptoms? And do I need to retest them?
Yeah, that's a good question. Dr. Pearl, you want to start with that?
I don't know the answer, and I'm going to ask Wendy to also comment. But what I would say is that I would treat this like any other respiratory virus, and assume that once their symptoms have resolved, that it's reasonable to go ahead and vaccinate them. What I would remind you of, children are very different than adults, but in adults, for those of you who are going to vaccinate adults, we do see somewhat of a two-phased presentation where there's the initial viremic phase where they have the cough, shortness of breath, they may have the loss of smell. They then will get better, and then they go into the immunologic phase, which is when they start developing the respiratory symptoms if they are going to develop a severe immunologic response. So you would want to wait until at least 14 days after that for an adult. I think just until we know more, and this changes all the time. But Wendy will keep me on, Dr. Chung will keep me honest and make sure I haven't said anything incorrectly.
Dr. Chung, your opinion?
Yeah, so I would agree with Dr. Pearl's comments and her observations about the course of disease, of severe disease in adults. I have not heard that there's any recommendations to that regard for pediatric population, and so I would also tend to concur that it would seem reasonable to proceed as if you would with any viral infection to ensure that the vaccinations are given after resolution of symptoms.
Excellent. Thank you, ladies. Dr. McHale from Dallas, Texas.
This is Dr. McHale.
Yes.
What is the most accurate test for active cases, and what's the instance of false positive and false negative?
All right, ladies, you fight over which one you want to take it. I'm getting smart.
So this is Wendy Chung, and I think that the emphasis again is that the PCR test at this point is absolutely the preferred test for active infection. And I would defer to Dr. Pearl for any additional comments she might have regarding accuracy, but at this point, by far, we prefer PCR testing over serological testing.
Yeah. I would say that, again, you're asking another $1 million question. And the reality is that the comparators between the different tests haven't come out, and nobody is really 100% sure what the sensitivity and specificity are. For the PCR-based test, in general, sensitivity and specificity is extremely high. However, they are very much sensitive to how well the NP swab is done. If you do not get a good sample and you have a low viral count, you can have a false negative. So that's the first thing. Some of the rapid tests that are not PCR-based do not have as high sensitivity and specificity. I haven't seen anyone publish those numbers yet, but I do know that there are concerns with some of the rapid testing that there are some false negatives. And in those cases, the recommendation is if you really think the person has it, to repeat in several days later and make sure. People do tend to have higher what are called CT, which is the count on the PCR when they have active symptoms, so earlier in the illness than later in the illness, if that helps. The other thing I would just say about testing is that you can have and identify the RNA that the PCR measures for weeks after this, even though the symptoms have gone. So do not be surprised if patients' symptoms have resolved and a test 3 or 4 weeks later is positive. The PCR is just measuring the RNA, and it doesn't know if it's alive or dead. And so there are reports out there that there are people who have had residual PCRs many weeks after their illness onset.
Thank you. Our next question is for Dr. Menchaca, is actually next online. So wide up from San Antonio.
Yeah, this is Dr. Menchaca. The question I have is, some studies are using a different age limit for masking from the CDC at 2 years or older. What are your comments on that?
So the question is the minimum age on masking. The CDC guideline, I guess, says 2 years. So comments on that?
So this is Wendy Chung, and I think that, yes, the CDC's guidelines recommend masking for source control beginning at age two years of age. So, I mean, I cannot comment about other jurisdictions that may have had a slightly different age cutoff, but that is what is the current national recommendations from CDC.
Excellent. We're going to go next to Dr. Birdwell, Henry Birdwell in Fort Worth.
Well, I guess I asked my question a little earlier, but it had to do with the being able to use telemedicine.
Yeah, I've got you. So you'd like to participate in telemedicine? You don't?
Yes, I would.
Have not been in it yet? Gotcha.
I've not been able to do that yet.
I think right. Dr. Silva is going to touch on that in just a few minutes, so maybe we'll go on. And next, we're going to move on to Dr. Valenti. So all good questions. We appreciate it. Thank you to those of you who asked them. We will provide another opportunity for you to ask questions a bit later in the call. This next time we'll be focusing on practice operations and then on telemedicine. So I would now like to introduce our next speaker, Dr. Joe Valenti, who is a member of the TMA Board of Trustees. Dr. Valenti will discuss how to keep your medical practice viable during and after pandemic. So Joe, thank you for joining us. Go for it.
Thank you, Dr. Flieger. First of all, I'd like to thank everyone on the call for the commitment they've shown to their profession and their patients. I'm really honored to be able to participate with you tonight. As you may be aware, the Texas Medical Association has been working on a practice viability plan and, in fact, published a Texas Medical Association practice viability toolkit, which is available on our website to both members and non-members. As many of you are aware, the biggest areas that we are focusing on at this time are the small business assistance loan programs. House Bill 748, which developed the CARES Act, which stands for the Corona Aid, Relief, and Economic Securities Act, was passed into law March 27th, and people were allowed to apply beginning April 3rd, and self-employed people April 10th. They're for groups of 500 employees or less, although for bigger companies, it's 500 employees per location. There are two major parts to this, the Paycheck Protection Plan, or the PPP, which was comprised of $349 billion of unsecured loans, and the second part was the EIDL, or the Economic Injury Disaster Loan, and both of these have undergone interim final rules from the Small Business Association on April 2nd and 3rd. I'll start briefly with the PPP. As many of you are aware, some of you already applied for this, others are applied and still waiting, and others still have been applied and been told the money's run out. The first bit of news is that Congress is passing another bill with $250 billion more dollars for small businesses, and the thought was that would be voted on today in the Senate and tomorrow in the House, but it's looking like tomorrow and Wednesday. So for those of you who have been applied and denied, just stay on top of your banks to make sure that your loan stays in process. Those loans are through any lender, including credit unions. You have to be open as of February 15th. The max is $10 million, or 2.5 times your average monthly payroll, usually taken from a 2019 census. It excludes portions of any salaries over $100,000, but it does include costs like health insurance, payroll, retirement benefits, mortgage interest, but not principal. It does not apply to independent contractors. For those of you who are independent contractors or employ independent contractors, it can't be used for those people. It can be used for rent and utilities, including internet. But under the new rule, 75% must be used for payroll costs. The amount is forgiven if used for an 8-week period of time, and if the part that is not forgiven can be paid out over a period of 2 years after a 6-month deferral at a 1% interest rate. Now, getting on to the EIDLs, these are longer-term loans, up to 30 years, and I think one of the take-home messages for this set of loans is this isn't just for the short term, but it should also be considered for the long term, and these loans can be applied for any time from January 31st of this year up until December 31st of this year. It's up to $2 million, and there was also a $10,000 grant, which is money that would not have to be paid back. That grant money was initially thought to be just $10,000 flat,
but the later interim rules changed it to $1,000 per employee up to $10,000. There's no personal guarantee on the first $200,000 in loans, but after that, you do have to have a personal guarantee if you're a more than 20% borrower with ownership. It can you can approve it without your tax returns, and some places are even using credit scores, but those are submitted directly to the SBA. Now, on the other side, outside of the CARES Act, you have Medicare advance payment systems, and for most providers, that was 100% of the next 3 months of their Medicare payments. Of course, pediatricians and OBGYNs like myself, not really seeing much Medicare wasn't that helpful. Including on the website are a number of different areas where you can look at individual loans, refinancing. There's also a lot of grant opportunities out there where IMTW or Texas Women's University offered grants to female-owned businesses. So a lot of options out there. I'm glad to take questions. I want to leave time for questions, and I'll help everyone as much as I can, understanding that my advice is not legally binding. So thank you for participating this evening.
Well, thank you, Joe. And once again, the COVID-19 toolkit, practice viability toolkit that the TMA's put together, go to our website, and it's easy to find. And Joe was very helpful in helping to put that together, as well as a number of other physicians and staff. And it's really, they did an awesome job. So thank you for your hard work. Yeah. So now it's time to go to our second poll question. Diana?
Thank you. Here's the second question. We want everyone to answer using your phone keypad. We understand from many physicians this pandemic has put a huge strain on practices. How much has your practice revenue decreased since the start of the COVID-19 pandemic? Press 1 on your phone keypad if it has decreased 0 to 25%. Press 2 if it has decreased 25 to 50%. Press 3 if it has decreased 50 to 75%. Press 4 if it has decreased 75 to 100%. Or press 5 on your phone if it has not decreased or you're unsure. Once again, how much has your practice revenue decreased since the start of the COVID-19 pandemic? Press 1 if it has decreased 0 to 25%. Press 2 if it has decreased 25 to 50%. Press 3 if it has decreased 50 to 75%. Press 4 if it has decreased 75 to 100%. And press 5 if it has not decreased or you're unsure if it has. We will tabulate and report the results soon. Dr. Flieger?
Great. Thank you, Diana. It's time for you to ask more questions of our panelists. A reminder to get in the queue to ask a question. Just push 0 on your phone. A TMA staffer will take your name and the gist of your question and place you in queue. We're looking now for a question about keeping your practice running during and after this pandemic. A few of you are waiting in the queue, and thank you for your patience. We're going to start with Dr. Frederick Atkinson in Dallas, Texas. Dr. Atkinson, your question, please.
Personal question. I am an 86-year-old practicing family doc on the advice of my PCP and myself. Since I'm in a vulnerable group, I have not been going to the office. I am in a group of 5 providers, so the practice is still going on. My question is, what will be the signal for me that I can reasonably safely return to work?
So let's start with Joe. What do you think?
Well, I think that sounds more like a clinical question than a practice viability question. But
well, you're clinical, Dr. Joe.
Yeah, I mean, we have been seeing patients selectively in the office, but we are screening them. And I think if you are going to see patients in your office and return to work, if you've been asymptomatic for 2 weeks, then I would strongly remind you to have your office staff screening patients at the front desk with both temperatures and histories. If there's anyone you feel should not be seen, then that person should be seen by telehealth and not in person.
And Dr. Pearl, your thoughts on that?
Yeah, I mean, I think you're in a very, first of all, I'm really impressed you're still practicing, so my hat's off to you. But second of all, you're right. You're in a group that's a very high risk for complications, and so you're sort of the person we don't want to get COVID-19. And when you go back to work is obviously up to you. I personally, at this point, would not want to go back to work knowing that there is still this much COVID-19 in the North Texas area. And I think you should wait until there's evidence that there's much less transmission and that we have more access to testing than we do. After that, honestly, it's really going to be a judgment call, but I agree with the recommendation the previous speaker wants, is that you do want to be very cautious about the kinds of patients you're seeing. You probably want to keep a mask on yourself, use very good hand hygiene, and assure that there's a lot of environmental cleaning. As much of your practice as you can do via telemedicine right now is really the best thing, I think, given your age.
Excellent. Thank you. I'm going to go on to our next question. Dr. Linda Esquivel from San Antonio on the line. Is that correct?
Can you hear me? I'm so sorry.
Yes, ma'am. No, you're doing great. Go ahead.
I think I was muted. Okay.
You got it.
My question was about serologic antibody testing. So I know that they mentioned not to diagnose. Obviously, you don't want to diagnose with antibodies. However, how about people that want to know whether they've had COVID in the past because they want to be able to get out, or they're healthcare workers, they've been asymptomatic, and they think they might have been exposed? Is there any reliable lab that could do antibody testing now, or do we still not do it?
Dr. Chung?
Hi. I think that I would defer to Dr. Pearl if she wants to make additional comments about availability of serologic testing. There's still so much that is unknown, and a few FDA EUA approvals that have been extended to some of this testing. So I would defer to Dr. Pearl if you have some comments.
All right, Dr. Pearl, your thoughts.
I would just say that really right now the serologic testing is pretty nascent in its development. And while there are one or two places that are either online or coming online, such as Mayo Clinic, you can do a send out. It's early. It should identify whether or not people have been exposed. What I would caution you all about is that most of the tests that are coming online are IgG, some of them are IgM, but there are certainly a group of scientists who actually think that a lot of this may be an IgA response, and so there are some future serologic tests that are going to look for all three, and that may be the best bet if people are just interested in looking at that. The other thing is there are going to be a lot of seroprevalence surveys that are going to be going on across the country in different groups, and so they could always try and get into one of those clinical research studies.
Excellent. Thank you. Our next question is from El Paso. Dr. Uga, or UGA.
Good evening. Thank you for putting this together for us. My question relates to the cross-reactivity in terms of testing between the COVID-19 and our usual seasonal flu. Now, those who have had the flu vaccine, how likely are they to test positive for COVID-19? Thank you.
So I haven't seen, this is Trish Pearl, I haven't seen any data on that. What I would tell you is that we don't really expect any cross-reactivity with influenza or the flu vaccine. These are different viruses. The targets are very, very different. So I wouldn't expect any cross-reactivity there. some of the preliminary data out there also suggests that there's no cross-reactivity with the endemic coronaviruses and the SARS-CoV-2 virus also. So we think that that the targets are directed enough that there's not going to be a lot of cross-reactivity at this point.
Excellent. Thank you. Our next question is from Georgetown, just north of here, and we have Dr. Florence Spittler. Dr. Spittler, your question?
Okay, so my questions are about, in general, the greater public wearing masks. If everybody is wearing a mask, there's a significantly decreased risk of transmission and, of course, washing hands and all good hygiene. So is there any data being collected in terms of the people who are getting sick, whether or not they were wearing masks prior to infection? And how are we gathering that data? And is there enough data to show that masks are being protective? And can we take that to our government to make it mandatory to wear masks in public so that we can aid in opening our businesses?
Great, thank you. Dr. Pearl, would you start that one?
Sure. So the first question is, it's actually a really good question, and I don't know, and I am unaware, Dr. Chung can type in afterwards, but I'm unaware of any large public health studies at this point that are looking at the efficacy of masking as a public health intervention across the country, to be very honest. I do think that there are probably, although I can't tell you specifically, some studies going on in healthcare settings looking at that. So that's the first question. The second question is pretty much the same answer, is that I'm unaware of any clinical trials right now looking at that, but I am guessing that there are some studies at least looking at whether or not this is what we call source control. It works where they may be culturing the inside of the mask and then the outside of the mask to see whether or not there is any virus on the outside once they isolate it if they isolate it on the inside. And then in terms of governmental mandates, that's so out of my lane that I don't even know what to tell you is going to be done in terms of measures. But I do think that if we get data, then we can certainly advocate for some public health guidance in that area if we get further data.
Very good. Dr. Chung, did you have anything you wanted to add to that?
No, I am also not aware of any current studies looking at efficacy of masking in community studies, in the community settings.
All right, very good. Thank you. Well, once again, thanks to all of you for your insightful questions. It's helpful to hear what's on physicians' minds about responding to this disease. We will have one final question and answer segment later in the call, focusing on telemedicine and technology. But first, Dr. Fite, you have the results of our second poll question.
Yes, and this is very interesting. We asked how much your practice revenue has decreased since the start of the COVID-19 pandemic, and I'm going to go in descending order. So the largest percentage, 36%, report revenues have decreased 50 to 75%, and then 24% of you have suffered a 100% drop in revenues. 23% have decreased 25 to 50%, 10% have decreased only 0 to 25%, and only 7% say your revenue has not decreased or you're unsure. Back to Dr. Flieger.
Ouch.
Yes, ouch is good.
We feel your pain,
yes.
Believe me. Now I'd like to introduce our next speaker, Zeke Silva, who serves on the TMA's Council on Socioeconomics and is co-chair of the AMA Digital Medicine Payment Advisory Group. Dr. Silva joins us to talk about preparing your practice to best utilize telemedicine to care for patients during and after this pandemic. Dr. Silva, thanks for joining us.
Thank you, Dr. Flieger, and thank you, Dr. Feit, for including me. So I love the question we just heard from our 86-year-old colleague, which what I heard in that question was a physician who wants to take care of his patients, but because of the crisis, because of the distancing, he's concerned about physically interacting with them. And that's the challenge we're facing within this COVID-19 crisis is how do we continue a high level of care while maintaining and protecting the safety of our patients and, frankly, the safety of physicians and our staff and other healthcare workers. The acceleration we're seeing with telemedicine during this crisis is really nothing short of dramatic. And to really appreciate it, and that is going to be the focus of my brief opening comments, let's look at some of the momentum that telemedicine had coming into the crisis. Because over the last few years, really we've seen quite a bit of activity in the telemedicine space, largely driven by just the evolution and the advancement of the technology, but also largely driven through the TMA and the AMA recognizing the importance of this technology, but even more importantly, the need for physician input into how it is applied in patient care. So as we've looked at the last few years, we have codes, CPT codes to describe obviously patient-physician interactions. We have codes to describe physician-to-physician interactions in telemedicine, such as consultations. We have several codes to describe remote patient monitoring. And to be fair, the ability to provide telemedicine services, it can be challenging. There's a pretty significant list of requirements and regulations that are driving this. For example, not all physicians can provide these services. Not all patients are eligible for these services. There are geographic restrictions. There was originating site restrictions. There were limitations on the technology. There were things regarding compliance, data ownership, HIPAA, et cetera. Take everything I just said coming into the crisis, now put it on the back burner. Because when the president declared the national emergency related to COVID-19, the telemedicine space completely opened up, again, for many of the right reasons I described in my opening sentence, which is our ability to protect and maintain distancing between physicians and patients. And it first started shortly after the declaration when CMS came out and said, well, we will allow telemedicine interfaces to occur, and we will pay them at the same rate as if it were an office-based encounter, a traditional face-to-face office encounter. Shortly thereafter, the CARES Act passed, and then there was an interim final rule, and the expansion was pretty dramatic. So instead of just being office-based visits, now it could be there were 13 or 14 different families of services, from emergency department care to critical care to home visits to cognitive impairment evaluation, neonatal ICU. And it was all beneficiaries in all locations that were eligible for this, including their homes. It was new, it was established patients, it was the ability to waive co-payments to better enable this technology. There was language about e-visits and remote patient monitoring now being not just for established patients, but for new patients, for acute and chronic disease. Many of the frequency limitations we've dealt with, for example, only being able in a skilled nursing facility to bill a telehealth visit or a telemedicine visit once a month, no longer applied. National coverage determinations that had face-to-face requirements, those no longer applied. And from a technology space, maybe this is where some of the most significant differences were occurred, because now the requirement previously was to have a two-way audiovisual interface. Well, now those interfaces, those interactions could occur by telephone, because we're finding that not every patient and frankly not every physician is completely comfortable or familiar with those types of interfaces. And those telephonic codes, if you will, are paid. For physicians entering the space for the first time that might be worried about some of the compliance requirements, they've loosened some of those as well. For example, HIPAA or security or the requirement for consent. So as we see these allowances and these regulatory burdens lowered, it's an opportunity for us to provide these services, again, for all the right reasons. So then the question becomes, okay, great, I love what I'm hearing. I'm excited to do this. I want to do this. So what are the resources to enable that? Well, there's a couple. If you just Google Texas Medical Association or TMA telemedicine, our splash page has pretty robust information about these technologies. One, for example, how to get started, sort of what the requirements are, how to evaluate vendors. If you need to have forms and policies in place, those are there to be downloaded and applied to one's institution. And I would say the same thing about the AMA, where we have a pretty robust telemedicine space that describes how those can be applied. Just briefly, I've talked mostly about Medicare. We're also seeing Texas Medicaid allowing parity between limited codes. We're seeing private payers where state-regulated plans must allow payment parity for telemedicine versus face-to-face, and this regulatory space is evolving relatively quickly. But just to repeat the point, and this is a temporary loosening of those restrictions during the emergency declaration. So just a very quick comment. So we're going to get past this. And once we're in the post-COVID period, we're going to look back at what is this one of the largest pilot experiments in the history of mankind as it applies to telemedicine. And we're going to look at what worked, what didn't work, what we need to keep, what we may want to evolve, what we need to get rid of. And it's going to be based on the quality of what we do currently, the documentation we provide, the patient experience. And we have physicians walking into the telemedicine space that have never done it before. And they're learning on the fly, and they're learning in a crisis. How are they doing, and how can we help them to be successful? And really, that's the reason why we put those together. And just to highlight one, on the AMA website, we have a telemedicine playbook that really walks through this pretty considerably. And again, just to compliment Shannon Vogel and her team on the really robust TMA telemedicine website and the resources it provides. And with that said, Dr. Flieger, Dr. Veit, thank you for the time.
Thank you, Zeke. So we appreciate your thoughts. Zeke is our guru on these issues, and we appreciate him advocating for practicing physicians, because some of this gets pretty technical, and he understands that, and he also understands our needs. So we appreciate his work. And now, Dr. Veit, you have the next poll question.
Yes, Dr. Flieger, our next poll question pertains to telemedicine. We know many physicians were not using telemedicine in their practices previously, but have adopted it now. Now, we'd like to learn how many are new adopters. So here is the question. Have you implemented and begun using telemedicine just since March 1st in order to safely manage and treat patients during the COVID-19 pandemic? So press 1 on your phone keypad if yes, you have very recently adopted telemedicine since March 1st. Press 2 for no. You did not just adopt telemedicine. I assume if you were using telemedicine for years, you would also press 2 because you did not just recently adopt it. So once again, have you implemented and begun using telemedicine since March 1 to safely manage and treat patients during the COVID-19 pandemic? Press 1 if yes, you have. Press 2 if no, you have not. We'll share the answers in a bit.
Now is your final opportunity to ask questions of our panelists. Remember to do so, just push 0 on your phone. A TMA staffer will record your name and question and place you in the queue. I'll then call on your name. So our next caller is Dr. Sanders. Is it Barry Sanders in Louisville, Denton area?
Thank you. My question is that if we were to try to seek the advancement from Medicare, what kind of bookkeeping nightmare do you foresee in the future when they withdraw the funds from future payments?
So, Joe?
Yeah, thank you, Dr. Sanders. That's a very good question. I don't think we know yet because I don't know how rapidly they're going to want repayment. Now, we hear it's 3 months, but we don't know yet. I know some physicians have already received some funds, some have not. I would make sure that if you get a check from Medicare, you maybe even consider putting it in a separate account, pulling on it as you need to, and then as they ask for it back, try to jibe it with your separate account. But it's a little hard to know because when they did this advanced payment, there weren't a lot of rules surrounding it yet. So I would keep it in a separate account and then probably talk with my CPA about when they're recouping it, what to do.
Excellent. Thank you, Joe. Next, we're going to go with Dr. Batra from Houston, pediatrician. Your question.
I'm a community pediatrician, and 95% of my patient population is Medicaid. And I know a lot of our colleagues are getting some kind of aid in that Medicare fee for schedule. And I thought I heard it from Seema Verma, I think she's the head of the CMS, that in the next installment, Medicaid and pediatric providers might get something. Is something happening? And is this in the form of an advance, or what form is it in?
Yes. Thank you for your question. That's another excellent question. Pediatricians and OBGYNs are both kind of taking a hit here, and we are some of the people who are most likely to need the PPP and the EIDL loans, as well as apply for other grants. There is discussion over Medicaid. Some of the things that are happening in Medicaid are there's currently expedited enrollment. They're recognizing a lot of the COVID diagnoses codes, and they're waiving a lot of the co-payments and co-fees. But as far as Medicaid grants or Medicaid, well, let me be clear first. The Medicare is not a grant. It's an advance payment, so that's going to have to be paid back, whereas a grant would not have to be paid back. But you're right that you are suffering like so many other people are, and I think that's where you've got to go ahead and apply for the PPP and the EIDL to kind of get you through the hump until Medicaid comes out with its national guidelines, or in our case, state guidelines. If it does come out, to answer the second part of your question, it'll almost certainly be an advance and not a grant.
Thank you. Thanks, Joe. Our next question is from Bryan, College Station, and that's Dr. Dave, D-A-V-E, or Davi, Arpit Davi.
Thank you so much for taking my question today. I have a question for the gentleman who presented on the various SBA CARES programs. My question is this. Is there any guidance you can offer regarding cost of goods sold versus cost of services when applying for EIDL or the payroll protection program should additional funding be secured for that? We have encountered some difficulty with CPAs in regards to how physician practices document their revenue versus their expenses in terms of cost of service versus cost of goods sold. Any guidance there for us?
Well, that's a really excellent question, and I think the trouble you're having with your CPA is that a lot of these rules and regulations came out in a very, very short period of time. I mean, I think that if you look at the payroll protection plan, for instance, one thing that has been suggested is that it not only covers rent, but some CPAs have begun to question, does rent include leased equipment? And so these are the sorts of variations on a theme that a CPA will have to give guidance on, but I think the SBA is going to come out on that as well. I think I would err on the side as being liberal as possible to secure as much money as you can, and then thereafter let the CPA sort it out, because the prepayment penalty, the forgiveness penalty for PPP, given that it's deferred 6 months and that you have 2 years to pay it off and it's at 1%, seems to suggest to me that even if it's not forgiven, you're getting such favorable terms, you might want to just go ahead with it. And I should say on the EIDL, that's 30 years at 3.75. And another point to keep in mind is the money that's advanced is not going to be taxable, at least by SBA rules currently. It's not going to be taxed as income.
All right. Very good. Thanks, Joe. Our next question is from Dr. Harry Thomas here in Austin, Texas. Harry?
Thanks, David. I have a question about pre-op testing prior to outpatient surgeries. Governor Abbott gave his speech on Friday, and I was wondering if the Texas Medical Association have any recommendations about approaches to pre-op testing for outpatients.
I'm going to have Dr. Pearl and Dr. Chung decide who wants to grab that one.
This is Trish Pearl. I can say that honestly, I'm not aware of professional societies really having gotten on the same page. There are certainly some groups that are recommending it. The most notable group where they've recommended it has been in women in labor as they've come in. I realize that's not operations, but that's where this asymptomatic testing has been done. It's been mostly done in areas that have higher prevalences than is currently reported in Texas. So I don't know how applicable it is. I can tell you that there are certainly, at least among academic centers, several academic centers that are starting to do pre-op testing, especially in persons where there's manipulation of the airway, which is the place you'd be most worried about it. And I think we have to wait and see what their data show. So I wish I could be a little bit more hopeful, but I just think it's another one of those areas where there's not a lot of guidance, there's a lot of opinion, and not a lot of data to support your opinion one way or another.
Yeah, and I've certainly seen that in surgery circles. There was a study out of China that had a 20% mortality on patients that ended up being COVID positive that had elective surgery. So I think that's got a lot of surgeons nervous and may have generated some of this, but I think you're right. We still have a lot to learn before we can make any definitive recommendations. Our next question is from Dr. Garza, Dr. Carmen Garza from San Antonio.
Hi, thank you for doing the TMA Texas Town Hall. A few of the physicians already asked my questions. I'm a pediatrician, and the one question that's left that I have to ask is about the telemedicine. I was informed during this COVID-19 time that the copay will not be charged to the families, and if that is true, most insurances now don't have just the copay. They make you do the $2,000 deductible. So if you could give me some answers on that for the telemedicine, I would appreciate it. Thank you very much.
Yeah. Steve, what do you say to that?
Yeah, no, it's an important question. So really, the intent of that update was to encourage physicians to provide these services to patients for all the reasons I described. And yeah, the ability that we have to waive those copays, which in normal times, from a compliance perspective, just wouldn't be allowed, is appropriate. And that would be co-insurance, and that, to my understanding, would include the deductible as well, to the point that telemedicine service would still be paid. And when we talk about parity, the parity we talk about is the telemedicine interface paying at the same rate as if that interface took place through what would otherwise have been an office visit, or if it's an ICU code, a critical care visit. You know, that's the parity that we're talking about, and the ability to maintain that by waiving the copay and the other patient responsibilities is an important part. It's a very good question. Thank you.
Excellent. Thank you, Zeke. And thanks again, everyone, for great questions. Dr. Feit, you have the answers to the telemedicine poll question?
Yes, we asked our audience if they have implemented and begun using telemedicine just since March 1st, and 74% of you said yes, you began using telemedicine just since March 1st. 26% said no, you have not. And now I need to ask our final poll question, CME evaluation question. This is that type of question you have to answer in order to get the CME credit. Which step will you take as a result of participating in this TeleTown Hall event? Press 1 if you will apply new public health knowledge or practices in response to COVID-19. Press 2 if you will use information learned to modify any business element of your practice. Press 3 if you will implement telemedicine in your practice. Press 4 if you will do more than one of the above, or press 5 if you will do none of the above. Once again, which step will you take as a result of participating in this TeleTown Hall event? Press 1 if you will apply new public health knowledge or practices in response to COVID-19. Press 2 if you will use information learned to modify any business element of your practice. Press 3 if you will implement telemedicine in your practice. Press 4 if you will do more than one of the above, or press 5 if you will do none of the above.
Excellent. Well, thank you, Diana. And we're nearing the end of our program for many of you tonight. However, if you joined us late, it took quite a while to dial up 60,000 doctors. So if you joined us late, please stay with us. Connecting with so many of you took so much time that we want to repeat the last portion what was essentially the first portion of tonight's presentation on the COVID-19 public health summary by Dr. Wendy Chung in a minute. For those of you who heard Dr. Chung's presentation, we'll wrap it up because you'll probably have met your magic 53 minutes there. If you were not able to ask a question of our panelists tonight but wanted to, please email TMA anytime at knowledge@texmed.org, knowledge@texmed.org, and TMA staff will reply in the coming days. Dr. Fite, I'll now turn it back to you to close tonight's TMA COVID-19 Town Hall meeting. Please, for those of you who don't wish to stay on the line, Diana.
Thank you, Dr. Flieger. We want to thank everyone who joined us this evening. We hope this TMA service has been beneficial to you. Our goal is to help you respond to this serious public health threat and to empower you to keep your medical practice viable now and in the future. I want to give special thanks to our speakers this evening, Dr. Wendy Chung, Dr. Trish Pearl, Dr. Joe Valenti, and Dr. Zeke Silva. I also want to thank our moderator for the event, TMA President, Dr. David Flieger. Physicians who remained on the call for at least 53 minutes will automatically receive CME credit. You do not need to do anything to receive that credit. Again, we have your number and a log of how long everyone stayed on the call. So if you listen for at least 53 minutes, you will receive CME credit. For more information about this evolving situation, please visit TMA's 2019 COVID-19 webpage, www.texmed.org/coronavirus. That's texmed.org/coronavirus. Once again, I'm Dr. Diana Fite, your TMA President-elect. To many of you, I will say thanks again for joining TMA's TeleTown Hall on COVID-19. And if you choose to hang up now and not stay for Dr. Chung's presentation again, good night.
But for those of you staying on the call, we'll now bring you a repeat of the program's first presentation delivered at the start of the event. The speaker is Dr. Wendy Chung. Dr. Chung not only leads TMA's COVID-19 task force, she also chairs TMA's Council on Science and Public Health. Dr. Chung will update us on COVID-19 epidemiology, testing, personal protective equipment, and recent efforts by the task force. Dr. Chung, thank you again for joining us.
Thank you, Dr. Flieger. And as mentioned, this is simply a few minutes of a recap for those of you who may have dialed in late and missed my few minutes at the beginning of this call. And so I wanted to just start off by sharing some numbers to give a general updated overview of the current status of the novel coronavirus pandemic in Texas. And as you know, the Texas Department of State Health Services announced the very first case of COVID-19 in our state on March the 4th. And today, just 7 weeks later, according to the Texas Case Counts Dashboard, we have reported a total of over 19,000 cases in Texas with 495 deaths. We have been encouraged to see a decrease in the rate of newly diagnosed cases over the last week or so, largely due in part to the shelter-in-place orders that were established throughout the state. But per the governor's recent executive order, as we look towards the prospect of reopening commerce, our communities, and our medical practices, we are looking to our state leadership to do so in a careful, science-based, methodical, and data-driven manner. The COVID-19 task force has been working diligently with TMA staff to produce helpful resources to address your public health questions on infection prevention and control, testing, treatments, what to do when you have PPE shortages, and more. These resources are available on TMA's COVID-19 Resource Center webpage. The availability of PPE has also been a top priority for TMA, and our association leaders, such as Dr. Flieger, along with task force members, have been actively advocating for the PPE that physicians out on the front lines direly need. We've also been working with other TMA groups with specialty expertise, such as the Subcommittee on Behavioral Health and the Subcommittee on Transplantation and Transfusion, to develop resources on physician and patient mental and behavioral health, as well as to address questions related to convalescent plasma and serological testing. Regarding testing, there are a number of tests for COVID-19 being marketed to physicians right now, some of which have not been granted an FDA Emergency Use Authorization, or EUA, nor have they been reviewed or validated for accuracy. We have heard of physicians purchasing these tests, which are appealing in terms of low price and accessibility, but these tests end up being unreliable. So we are recommending to those listening to please remember to check the FDA EUA website to make sure that the company and the tests that you are interested in purchasing have at least been granted FDA EUAs. Also, since TMA has been getting many questions about serological tests or antibody tests, I wanted to take the opportunity to explain further. Many serological tests are being inappropriately marketed to doctors as a way to detect SARS-CoV and to diagnose acute infection with COVID-19. However, serologic testing should not be used to make this type of diagnosis of active COVID-19 infection because antibody production is not present at detectable levels until several days after symptom onset. This is why, at this point, serologic testing is not approved by the FDA as a diagnostic test for COVID-19. Instead, we are looking forward to seeing serologic testing playing a role in helping to identify which persons, such as healthcare workers, may have had past infection and therefore some level of immunity to the disease. And serologic testing also currently has a role in confirming which individuals can donate convalescent plasma. We want to emphasize that whenever possible at this point, clinicians should rely on molecular or PCR tests to diagnose the presence of active SARS-CoV infection. And FDA at this point approves only molecular testing for this diagnostic purpose. So that concludes my remarks, and I am wanting the audience to know that the TMA Task Force is committed to continuing to be a resource for you. Thank you again for this opportunity.
And thank you, Dr. Chung. We appreciate you for providing this valuable information and for doing it twice, working extra hard for us as the task force does as well. So we appreciate it. Diana, I appreciate your work this evening, and I'll hand it to you for tonight's final conclusions.
Thank you, Dr. Flieger. Once again, we want to thank everyone who has stayed on the call. Again, we thank our speakers, Drs. Chung, Pearl, Valenti, and Silva, and our moderator, Dr. Flieger. For more information about this evolving situation, please visit TMA's COVID-19 webpage, www.texmed.org/coronavirus. That's texmed.org/coronavirus. Once again, I'm Dr. Diana Fite, your TMA President-elect. Thanks again for joining TMA's TeleTown Hall on COVID-19. Good night.